Thank you, Dr. Anju. I think it's always a pleasure to be back in Lucknow, to be with Viji and Preeti and rest of the colleagues. Love to see the young faces and also not so young face of Margaret. I think whenever I come to Lucknow, Margaret is always there. Love to have you hear words of wisdom and experience in between. I am still in the process of learning. So my talk will look like most probably an undergraduate talk because I learned that many things are not still clear. After writing, I think 3 chapters in many pediatric endocrine books on precocious puberty, now I think that chapter title is wrong. Probably we should be saying early puberty than anything else. And then try to say when to intervene and when not to intervene. And I think Viji and Preeti, you have been very unkind to me to restrict it to girls because very little information is available on new aspects of. I was last month onwards, I have been busy searching PubMed to see what new has come. After 2016, I cannot find any original research in this field. So I will see what I have seen and experienced as my basic aspect of the thought. You will see a few slides which are actually copied from my colleagues who has helped me with the book. I'll restrict my talk to these. If you see a lot of material on your slides, it is because I want to tell you I know all these things, but I will speak only a few about it. So let us just see what are we seeing in the pediatric endocrine clinics, at least in my practice. We see very young girls like this 2-year-old girl brought with history of 3 episodes of tonic-clonic seizures, uncontrollable laughing spells, hyperactivity since the age of 1 year 6 months. Originally seen not by pediatric endocrinologists, a simple pediatric resident referred to a pediatric neurologist. Under follow-up for 3 months, the neurologist now thinks it is a developmental problem because ADHD is associated, goes to developmental pediatrics. It is the bane of actually that having so many specialties, it goes to different people. Non-consanguineous parents, no significant birth history, early development other than this ADHD seems to be all normal. The girl is tall. She has pubic hair, which is somewhere in the early pubic hair stage 3, no axillary hair. He has got doubtful some acne over the forehead, nothing on the face. Looks little muscular when you look because the resident had written that baby eyes looks muscular. No neurocutaneous markers. An X-ray of born age showed born age of 3 years. Had serum estradiol done by the resident was high. LH in the pubertal range. So obviously everybody knew about hypothalamic hamartoma. Immediately, they contacted the pediatric radiologist. They did an MRI brain. Quickly, the diagnosis came as hypothalamic hamartoma. Now, the question was to start on GnRH. That problem we will see a little later. More commonly, we see children around 6 to 7 years of age who comes to our OPD with early enlargement or early appearance of the breast bud or stage 2, stage 3 state development of breast. Parents are non-consanguineous, no history of early puberty in either. Antenatal birth history, everything is uneventful. The child appears to be in the upper normal percentiles for height and weight within the average. Breast stage is stage 3, pubic hair stage 1, no axillary hair. General physical examination, everything is normal, no pigmentation, no neurocutaneous markers, no organomegaly. A bornage was done immediately. I think our endocrine teaching was very good. So we got the bornage immediately, same day. It is consistent with the chronological age. We were not sure. The residents went ahead and did the hormonal evaluations. and estrogen, LH, and FSH of this 7-year-old girl were all within the normal range for the laboratory. So the question was, is this girl with breast or thelarchy with a slightly higher weight normal or abnormal? Should we do anything? The considered opinion was it is probably a simple case of idiopathic central precocious puberty. We will wait and watch. We will not do any intervention, just advise them and ask for follow-up. Occasionally, you come with unusual problems. For example, this 8-year-old girl was referred to me by another pediatric endocrinologist. She was first seen by a gynecologist because she had early onset vaginal bleeding just 4 days prior to her referral. 2 weeks back, it was noted by the girl. The mother was told about it. She was very concerned and consulted an obstetrician because she did not know whether to go to a pediatrician or obstetrician. The parents were very tall from from Telangana, with history of relatively early menarche in the mother. She says that she had her menarche at the age of 10. Non-consanguineous marriage. The child was born at 37 plus minus weeks, appropriate for gestation. Every developmental aspects were normal development, bright student in the class. Her height is again within the 90th centile. Tall, weight is also good, around the 90th centile, normal body proportions. Breast examination shows stage 1. There is no pubic hair, no axillary hair, no apocrine effects. Genitalia appears perfectly normal. Born age normal. The resident and the obstetricians were concerned because the parents are told there is early history of puberty, menarche in the mother. Is this an unusual early puberty? Should we intervene? So they investigated the girl. Estrogen, LH, FSH were all in the prepubertal range. They did an ultrasound. A well-trained sonologist said that abdominal and pelvis showed prepubertal uterus and ovaries. So the question was at that particular time, should we do anything to stop further cycles in this child or just leave her alone? The mother was extremely anxious about this puberty. The girl was not really worried. So while we were planning for this investigation and she came over to me, then I asked her about the thing. Then she suddenly asked me, why everybody is asking you about this bleeding? I just fell down the stairs. But I told my mother, but she was not bothered. So again, we called in the gynecologist. They did an examination of the genitalia. There was no real tear or anything that we could notice, but we thought this is probably an incidental injury which has caused the menstrual bleeding. We will just wait and watch and follow. So you see all sorts of presentations coming with early puberty in various manifestations. For shortage of time, I am not going to more cases now. So the question is that we have a tendency as a postgraduate to go by these critical definitions and then stick to this level on either side of the range as normal, abnormal, and start investigating. So any girl by all standard textbooks with a onset of development of secondary sexual characters before the age of 8 years is all termed as precocious puberty. Truly speaking, there is no cutoff of said about what is the actual age at which menarche occurs. In Indian studies by K.N. Agrawal et al. And then subsequent studies, there are a lot of studies on age at menarche, but there are no real studies to show the different stages of puberty in Indian girls. So we are going by Western standards. Then you all know that the Lawson-Wilkins Society said that the Caucasian American girls develop puberty at an earlier age. Our mothers are also coming with saying that my girl is maturing faster. And then the question was there about whether we should bring down the definition of precocious puberty to 7, 6. These questions always pop up. But there are no studies anywhere to show that the mean age at which puberty or the secondary sexual character is changing in Indian population. We are just following the Western cutoff. So we have to be very, very careful about using data and analyzing. So even in my book, I have used this particular cutoff as the for definition of early puberty. We all know that puberty is this a coordinated action between the hypothalamus, pituitary, and the gonads. And we all know about that there is a GnRH in the hypothalamic area, which has got pulsatile action and start activating at a particular age threshold, or the hypothalamic stat is the gonadostat is there, which decides what time the anterior pituitary will become active and start producing the gonadotropins, and then we'll start with the development of follicles and other activities in the ovaries. But very little is known about the interactions. So we will just come back to this in a bit of time as we understand about the various causes or the diagnosis of precocious puberty. Theoretically, we all say that if it is due to an activation of the hypothalamic pituitary gonadal or ovarian axis, it is central precocious puberty. All of you know it is a gonadal-dependent isosexual precocious puberty. And if the estrogen is coming, or the gonad activity is due to, or the manifestations are due to extraneous production of androgens, either from the ovary or from the adrenal or from any extragonadal site in the body, then we call them as pseudo precocious puberty. Many a time it is very difficult to find out whether it is starting with central or peripheral, and then clinical evaluation and hormonal testing may be necessary to find out the source of the extra activating androgen or estrogen in a particular girl to decide whether it is producing isosexual or heterosexual precocious puberty. And to complicate into this, there are many, many normal variations in which the girls just go into an isolated telarchy or breast development to start with, but does not progress further into any other stages of puberty. We are waiting for that to see whether more investigations are needed, or sometimes things go contrary. They don't go in that order. They come out with early pubic hair, early axillary hair, or early onset of menstrual bleeding. So all these variants sometimes confuse. How do we go about investigating them? So generally we look at central precocious puberty. All of you probably know about all the causes which are highlighted on the left of the slides. As we go, we now see that we are trying to see more of genetic and syndromic forms of puberty now, central precocious puberty, primarily because now we have facilities for testing and for investigating, and then we are able to pick up these ones. So what we are going to see is that in literature, which I could review till this year, August, we see that idiopathic central precocious puberty seems to be the most common form of precocious puberty in all studies that is done so far. And idiopathic is much more common. It is 5 times more common, or what we call as more than 90% of all precocious puberty in wherever long studies have been done all over the world. Organic underlying pathology is seen mostly in boys, especially who are very young, and very little is described in girls in general. And then what we have seen is that if you see a girl with precocious puberty or premature telarchy developing over a period of time, and if the girl is around 6 to 7 years, 7 to 8 years, 8 to 9 years, and evaluate them whether they will go into complete puberty or will have an underlying organic disease, many people have really looked at to see whether it is a rapidly progressive precocious puberty or a slowly progressive puberty. What they find is that whether it is rapidly progressive, whether it is early progressive, after the age of 7 years, the outcome seems to be the same. Their target height is the same, the period of menstrual cycle or menarche seems to be onset. So not much difference is there after the age of 7 years. But if the girls are less than 6 years and it's a rapidly progressing precocious puberty, the chances are that there would be an underlying pathology. So these children, these girls need more extensive evaluation. The problem has now come because there are multiple publications now come that early onset of puberty with the onset of obesity. Obesity is increasing worldwide. So increasingly, you will see more girls coming to you with the premature telarchy or even complete onset of puberty. Whether it is part of the obesity syndrome or whether it is just incidental, we are not still clear at the moment from the studies. So we are just looking at when it is so much of idiopathic, if you don't know the reason, you go to the genetic lab, consult your genetician, and then do a lot of studies. So now a lot of genetic associations have been found, both isolated abnormalities in a particular gene or syndromic association with precocious puberty. And I'm just listing the common ones that are described. And the common one is MKRN3, which is the Macorin ring number 3. Here actually what happens is actually an inhibition of the HBG axis. It is the inhibitory action that is happening. Whereas if you are looking at the KIS1 or the Kispeptin1 or Kispeptin1 receptor genes, they are actually producing the effect by a stimulation of the HBG axis. So there seems to be different mechanisms involved in the induction of precocious puberty or early puberty in girls or even in boys when it comes to these genes. So now there have been quite a number of studies which are looking at where exactly these genes are acting in the hypothalamus or in the pituitary or in the target tissue cells. So on the right diagram actually shows that different areas of the hypothalamus, whether it's in the periventral PMV nucleus or the AVPV nucleus, you can see that different abnormalities produced by different genes are actually can be targeted to these particular nuclei or the tract. For example, hematomas are commonly associated with abnormalities of genes associated with these particular cells near the Kipseptin neurons in the AVPV. Whereas if it is a stress-induced or nutritional, then there are different other neurons which are getting activated. So as we learn about more genes, probably we'll understand how exactly the abnormalities are shaping up and is producing the disease. And then probably will give us more guidelines as to how better to manage this puberty. It is very common to see peripheral precocious puberty, but it is compared to boys, PPS is much less common in girls. And in girls, ovarian lesions are much more common than adrenal pathologies, even though a wide variety of conditions are there. But if you look at published studies showing what is the lesion seen with peripheral precocious puberty, autonomous secreting follicular cysts of the ovary are the commonest cause of peripheral precocious puberty in general in girls. So you can target your investigation to this one with a good sonologist and with appropriate endocrine evaluation. The problem comes when a girl comes to you only with the first sign, that is premature telarchy. Are we just going to be deciding whether this is just an isolated one-time event which will not progress further, or is it the beginning of a child who is going to enter into early puberty with menstrual cycles? It seems that long-term follow-up studies on isolated telarchy show that majority of the children do not go into complete precocious puberty. they just remain static, and many of time it is also seen that they regress. The puberty telarchy also regresses over a period of 2 years. And there is two types of premature telarchy that we see, one which just comes immediately in the infancy, and a later form which comes after 4 years. It is seen that those who get premature telarchy after the age of 4 years tend to persist with that telarchy, even though their progress into complete puberty is variable. The neonatal and infantile forms of telarchy tend to regress over a period of time. Why do this happen? It is still an enigma. And many people suggest that is because of the increased sensitivity to the estrogen, or it could be a transient estrogen secretion from the follicular system of the ovary. So there may be a need to look into the ovaries with good sonology. It could be that a great amount of estrogen can be coming from other sources, mostly from the adrenal precursors that are there, or it could be simply a early activation of the HPG axis. But what now comes with studies in the Middle East, Turkey, and other regions is the prevalence of environmental agents. And essentially, while I was working in Kuwait, everybody used to say that, oh, my daughter is probably just eating KFC, chicken, McDonald's, and that is why she is getting into puberty. This is a common complaint by the mother. So we are also now getting into that thing, whether our food processing, food delivery is also related to the development of higher incidence of telarchy that we see in the population. But generally, most of the girls that I have seen have not really progressed to that stage where short stature is a problem. That comes to where does this particular telarchy comes from? It comes from probably adrenal androgen production, or it could sometimes be just a hypersensitivity of the hair follicle to steroid hormones. And generally it is benign. But these are children, probably those who come with premature puberty, who should be evaluated for the development of polycystic ovarian syndrome in later. There is quite a number of association studies in premature adrenal. Premature menarche is still a local cause, and you should actually be thinking and examining and getting the consultation of a trained obstetrician or a gynecologist before you get in with investigation for this particular. Most cases of reported isolated premature menarche have not gone into gone as a child with short stature in the follow-up studies till now. So based on these factors which are available, I think how do you proceed to evaluate a child with precocious puberty? It would be the same as any child with short stature that you have seen in the phonic lectures. Age at onset, family history of pubertal onset, curiosity. It is very common to see familial idiopathic forms of precocity, tempo of pubertal progression, growth acceleration, whether the development of pubertal signs are identical, symmetrical, including the and in the orderly fashion which we know about puberty. Also look for other associated neurobehavioral problems. Occasionally, we would be concerned about hypothyroidism, but definitely you should be looking for a abdominal mass. A lot of environmental factors have been reported, with mostly case reports in the literature recently, which mostly are using cosmetics, care, skin care products. But these seems to be very common now. But of late, which is coming, few reports from India also is related to the use of plastics. This is bisphenol and phthalates, which have come up as a particular environmental disruptor for producing precocity in children. But diagnosing this would be very, very difficult in our setup. So we should evaluate primarily based on oxology, which all of you are very familiar with. And I think we had an extensive session on growth charting, so I would not go into that detail. At a given time, you may be either above the upper limit or within the normal limits. So it is very important to have regular monitoring of growth and charting. It's important to decide where exactly the child is going to end. One thing we probably forgot to mention in the growth chart is that simultaneous recording of the SMR. I feel that every growth recording, like for example, at this stage, somewhere below, there should be a record of what was the SMR chart to know whether the child's pubertal development is coordinated with the growth that is occurring. So learn to chart your growth chart, both not only in height and weight, but also with the SMR range also. When I was working in UK in 1981 to 84, we used the old Tanner's growth charts, which had the pubertal development different stages with the standard percentiles. But now we do not get those type of charts anymore at all. Puberty has been discontinued from growth charts. But I think we should still continue to record puberty along with height in all cases of endocrine disorder. It is important for you to record the SMR appropriately in the growth chart as well as like the beautiful chart which are shown by Dr. Vandana in the DSD cases. Record the pubertal stage or draw a diagram. Physical examination, in addition to oxology and Tanner, should be looking for skeletal deformities, which you know, which are the conditions which are associated with that. They are rare, but do not miss them. Examine the child properly in daylight or good light, properly with appropriate supporting family member or help. It is important to examine all aspects of genitalia and secondary sexual characters in this. In addition, you should also be looking at the skin texture, look for features of hypothyroidism, palpate the abdomen for masses. It is very important. Once you have clinically made a diagnosis that this is a case of precocious puberty, then probably you will probably go ahead with a evaluation of the hormonal profile in addition to other routine tests. The review of tests done to diagnose precocious puberty currently shows that testing the basal sex hormones are not as rewarding as it was thought to be. This is primarily because estradiol levels, there is a big overlap between the normal puberty, pre-puberty, early puberty, and precocious puberty, and even premature childhood. So estradiol by itself does not distinguish whether it is low, normal, as a cause of precocious puberty. So some of the textbooks, pediatric endocrine textbooks written by experts mention that any level more than 20 picogram per ml suggests that puberty has started, but doesn't mean that it is precocious. But what most experts are sure now is that if there are markedly elevated levels of estradiol, many say 75, some say 100, but I generally take 100. That means this child needs more investigations and further workup for evaluation of precocious puberty. Compared to that, estimation of LH would be probably much more useful. So if you have to choose among a test in a setup with limited funds, then go for simple testing of LH. That would be the best test that would be possible. There are these values which I have shown on the slide are from the AIMS lab or from the lab, but you should have a lab with experience in testing for children with a normal levels established for the lab. This is very important because I have found that LH levels in most commercial labs are not coordinating or with the levels of normalcy. It may just be telling what is the level in an adult. So be sure talk to your endocrine biochemist when the values come. If you are in doubt, definitely you should do a stimulation test. In our days, it used to be GNRS stimulation test. It was available. Now I think it is not available in India at all and in most countries. So we are still doing the conventional GNRH agonist analog test, which is done by a standard doses as shown in this particular slide. What we are going to look for is essentially the LH levels. If the LH levels are more than 6, then definitely you are on the right track of diagnosing precocious puberty. I would be a little more cautious if using comparison between LH and FSH, the LH-FSH ratio, even though they are written in textbooks, including my chapter, I find that sometimes they could not be very unreliable. Sometimes I am asked this question by PGs, whether stimulated estradiol levels will be a good test. There is no real proof from textbooks or studies, but generally I feel that a value which is more than 50 picograms probably is a good indicator of associated precocious puberty.
So may I intervene?
Yeah.
Thank you.
Yeah. Born age is good. All of you heard about it. Ultrasound is equally important. Nowadays, point of care ultrasound is also available. So it is very important to know what are the measurements of the various internal genitalia. You can do additional tests depending upon what are the clinical features. The only thing that is new is inhibin B. Now people have found that the levels of inhibin B increases progressively with the stage of puberty. So if you can have levels of inhibin marked for the age and puberty, then they can be used. They may not be very good for diagnosing precocious puberty, but it helps in monitoring precocious puberty. That is hematoma, I think you saw earlier. So what are the red flags that you have to look for? Short stature, delayed born age will suggest hypothyroidism, abdominal mass, ovarian cysts would look for example, Van Wijk-Grumbach or adrenal malignancies, ovarian cysts, if you have headaches and neurobehavioral symptoms, maybe an underlying SOL in the brain, isolated pubarchy in the girls, and very high estradiol levels. These would be the red flags which make me think for. So when your standard investigation goes, there is nothing really new. I was really looking, are there any guidelines for doing genetic studies in precocious puberty? There are no guidelines. What is generally said, if it is idiopathic and if it is familial, or there is a history of precocious puberty in close families, then probably you go for genetic study. Otherwise, there is no real indication. I think all of you have seen, or some of you must have seen McCune-Albright syndrome with the characteristic cafe and the classic abnormalities. Just 1 minute. The management is very clear, but when to use GnRH agonist analogs are probably the questions many a time asked. In very early puberty, it seems to be the right choice. So I will just go, because this is available as a depot preparation in strengths of 3.75, 11.25, and in Kuwait and in Middle East, it's also available as a preparation of 22.5. So the question sometimes confused as to what is the dose to be used. There are no dose-based recommendation for treatment in precocious puberty. What I can find is that older textbooks, older books used to mention about a particular dose, but now there is no dose-based, and maybe you can go for a higher dose in those who are more than 30 kg. In India, I find that most of us are using 3.75 milligrams every 4 weeks. But in Middle East, many people are using 11.25 milligram depot preparation once in 3 months. One of my cases went over to USA, was seen by two experts in Cleveland Clinic with a correction of my prescribed dose from 3.75 in a child with hypothalamic glioma with a dose of 16.5, because they thought that this child needs much higher dose of. So individual expert perceptions may change. It is important to monitor them regularly, and the single best monitoring technique is to do LH monitoring. That would be the best way to monitor. The commonest adverse effect that I have seen is the development of sterile abscesses at the site of injection, especially if you are going to use thigh as the area of injection for this child. So there was very little knowledge about the management of precocious puberty peripheral. So to summarize, onset of secondary sexual characteristic before the age of 8 years in girls is precocious puberty. It is idiopathic in most of the girls, but it needs evaluation for an underlying cause in those who are less than 6 years. The best diagnostic test probably is estimation of serum LH. You can do a stimulation test if you want to confirm. The treatment of choice is GnRH analog. Short stature and delayed bone age with precocious puberty is suggestive of hypothyroidism, and management of PPP is generally unsatisfactory. There are quite a number of good references, but I could find good references only in 2022 to 3, very little. So if you have found something new, please tell me. Thank you.